comes for me. It comes for me. All right. Okay, so we're going to run through this study session 1, and then let's see how it goes. And while we're at it, please, we need somebody to help us with tomorrow. Please, we need somebody to help us anchor tomorrow's discussion, right? Please, so that we can keep our marathon going. Okay. All right, so epidemiology introduction. Um, when we learned the definition of public health, I think part of the things it said was that it is an art and science. It's both science, it's both a science and it's also an art. Okay. So, the science part of it is the part where we are trying to generate evidence. We're trying to understand how things work regarding health and, health in populations. We're trying to understand all of those. So that's why they said it's a science, because we're using scientific methods to try to understand health in populations, right? So that's the science part of it. And then the art part of it is now when we talk about application, that we're applying what we have learned into improving outcomes. So although it's not clear cut, it's not like you can say, yes, this is where the science is and this is where the art is, right? But to a good extent, epidemiology is more on the science part of public health. Okay? So epidemiology is more on the science aspect of public health. It's the major science actually in public health, under public health. So biostatistics is there, and like environmental health science is there, you get. But epidemiology is like, this is the main science when we are talking about public health. So it's the backbone of public health, right? So this study session, we're going to do our best to run through it. And I'm going to so it's like divided into 5 parts. This study session, we are going to look at 5 parts to make it so that we just have it at the back of our mind. The first thing we're going to look at is the definition and core functions of epidemiology. That's the first thing we are going to look at. Then the second part of this is where they talk about the historical development of epidemiology, right? Then we're also going to talk about key concepts of disease causation. We're going to talk about natural history of disease and levels of prevention. And then the 5th thing we'll talk about is measures of disease frequency. So they are like, you can divide this chapter into 5 parts. You can divide this study section into 5 parts. There's the definition and core functions of epidemiology, the historical development of epidemiology, the core concept as regards disease causation. Then we're going to talk about natural history of disease. And in line with that, we talk about levels of prevention. Then the last thing in this session is measures of disease frequency. So I have to mention that we are going to skip the historical parts of it, the historical development of epidemiology. That part, we're going to skip it. Because yesterday we talked a lot about, when we're talking about foundations of public health, we talked a lot about the history. So most of the things that we are going to see, epidemiology it's under public health. And the course we did yesterday was foundations of public health. So a lot of the history in epidemiology, it was already mentioned in the foundations of public health, that study session 1. So we're going to skip that part. And if you were not in class yesterday, like you can just look at the video of yesterday, to just get a feel of the history. Most of the names there, they are the same thing, the same names you're going to encounter here. That's why I'm like, let's just skip it and, move ahead. So let's now talk about the definition of epidemiology. Let's talk about the definition of epidemiology. Okay? So epidemiology is, let me go down so that we can all see the screen. We're done with introduction. Okay, so we can look at this, should I call it yellow? The pale box there, would see the definition of epidemiology. So what is epidemiology? Epidemiology is defined as the study, is defined as the study, is defined as the study of the distribution and determinants of health-related states or events in specified populations, and the application of this study to control health problems. So we're going to dwell on this definition for a bit because epidemiology is like a key thing in public health. We're going to dwell on it a bit just so that we can understand it. Okay? So when we say epidemiology is a study, we say it's a study because we've already established that it's a scientific discipline. And then it's a study because it's using systematic observation. It's not based on personal opinions. It's not based on beliefs. It's not based on what people think. It's a study because it observes things systematically. And also there's data collection there, and then there's statistical reasoning there. That's why we say it's the study. So it's not an opinion. It's not, what somebody felt like. It's study, it's systematic, and we are using scientific methods in our study. Okay, that's one part of the definition. Now, the second part of the definition of epidemiology, it says, is the study of the distribution and determinants. So we're going to talk a little about this distribution and determinants. I've said it in the previous classes, so we're going to be a bit fast. When we say distribution, we're talking about, how to describe diseases in terms of person, in terms of place and time. So who are we interested in studying? And when we say who are we interested, you should tell us the age. It's part of describing the person. The age, the gender, it's part of description of person. Then we talk about that's for what's it called? That's for person. Then we talk about when. At what time does this thing happen? If you remember in the history, there was one of the persons who was able to say that this thing happens periodically, that there are diseases that, he was able to establish seasonality to say there are diseases that occur at different times. So for instance, malaria, you see that there's a time where it peaks, and then there's a time where it's not as common as it was. So when is this thing happening? Time, right? And then where, we have to describe in terms of place, which region is affected, which country, which geographical location is affected by this thing. That's distribution. Then when we're talking about determinants, we're talking about all the factors, factors that can affect health, like social factors, economic factors, level of education, etc. So we've said epidemiology is the study of the distribution and determinants. We've established those two parts of the definition. Study is a study first. Then what are we studying? Distribution and determinants. Okay. Now take note of the next thing. We're studying the distribution and determinant. It did not say of disease. It said of health-related states or events. It's usually shortened as HRSC, health-related states or events. So it's not just disease that we study in epidemiology. It's not just illnesses that we study in epidemiology. In the previous sessions, we said it a lot of times, how that, how that we are finding that there are a lot of things that contribute to disease, and wellness. So it's not just to health. So it's not just disease that we are focused on studying. We are studying things that are also related to health that may not be diseases in themselves. For instance, we study health behaviors. We study health behaviors, how people's behavior as regarding their health. We study it in epidemiology. We study things like events. Events are things like births, like people giving birth, people dying. We study all of that. So because it is not just diseases that we study, that is why it is referred to here as health-related states or events. And then remember that this is epidemiology, so we are not talking about individuals. If we are studying just for individuals, it will be clinical medicine, but this is epidemiology, so in specified populations. Now, the thing that makes it also good is that, or the thing that separates epidemiology from pure statistics, because statistics, you would notice that it may be a bit similar to epidemiology, but the thing that makes it different also is the fact that in epidemiology, we are not just stopping at studying. We're not just stopping at, getting data and analyzing and all of that. We're taking it back to how can we apply this to improve health outcomes. So that's the definition of epidemiology. All right. So let's move on to talk about the core functions. That's the next thing we're talking about. So for the core functions of epidemiology, there are 5 according to our material, right? So there are 5 core functions of epidemiology according to our material. Because we may go out and you see, okay, maybe there are more or something. So what are the functions of epidemiology? Number 1, we have disease surveillance and monitoring. Disease surveillance and monitoring. So what's happening in disease surveillance and monitoring? From the name, it's like we're standing on guard. We're standing on guard and we are watching out. We are monitoring. We are observing. We're taking note of things. We're not waiting for something to happen before we become concerned. No. So we are always monitoring. You see, that's why, for instance, hospitals, the patients they see, they usually like make a report and send it to the health bodies, to the maybe state ministry and the state's health bodies. They send all of those data to it. We saw 10 patients that had this disease. We saw 20 that had this one. 5 of them died. This one survived. All of those data, it goes up. It doesn't just stay with the hospital. Why is it going up? Because we need to monitor trends, and the only way we can monitor trends is if we have data. So we're not waiting for things to take us unaware. That's what this disease surveillance and monitoring is. So the key word here that we should note is continuous. So it says it is one of the primary roles of epidemiology is the continuous and systematic collection, analysis, interpretation, and dissemination of health data. That word continuous is key. It also goes to tell us that it is, although it's not here, but we should just know that when we talk about surveillance, it's a proactive measure. We should note that it's proactive because we are going to see that also in epidemiology, we have to study disease outbreak, and that one is a reactive measure. So disease surveillance, note the word continuous. Okay? So we are collecting data, we are analyzing data, and we are interpreting it. And we are giving information based on this health data. We are trying to monitor trends. Because if we're not monitoring trends, how will we know when maybe Lassa fever, when there's a Lassa fever outbreak, for instance? But if we have that all of the health facilities, they're sending data, and then we're able to monitor, and we see that we're having like 12 cases of Lassa fever. What's happening? We have to now go and do something. Do you understand? So that's why surveillance is important. We don't wait for things to take us unaware. It's proactive. Okay? Now that's for disease surveillance. The next function of epidemiology is disease outbreak investigation. So it's almost like a continuation of disease surveillance and monitoring. What's happening here now is that, so you are watching the trends, we are watching the pattern. You as an epidemiologist, you are looking at the trends, and you are seeing that this particular disease, as of last year, let me say we just had maybe about 5 cases, and let me say for the past 5 years we've just been having like 5, 6, to 10 cases, and all of a sudden this time we're seeing 20. Now what's going to happen? There's now going to be something called an outbreak investigation. We now have to go to say, where is this thing happening? We now need to go to that place and locate what is happening, identify the source of, if it's, let me say, a disease. We go and identify the source of that disease. We go and check we characterize the disease. We try to learn about it. We say, okay, what's the onset time? What's the incubation period of this disease? How long does it take from when the person gets the disease causing agent to when the person starts showing signs and symptoms? What's the mode of transmission? How is it transmitted? All of this information. What are the risk factors? So by the time we now do our investigation, we can now come back to the public and say, we have to do lockdown. No, we have to do lockdown. That was the kind of thing that happened during the COVID period. So the epidemiologists, they were at the forefront of it. They studied, and then they said it's the mode of transmission of this disease. It requires that we observe some sort of social distancing. It requires that we observe some sort of lockdown so that we can contain the disease. So that's outbreak investigation. Okay. Now we're going to move ahead. The third function of epidemiology is risk factor identification or analysis. Now here, this is where we are uncovering associations, like, all those things we explained when we're talking about research, using observational studies, like all those case control, cross-sectional cohort studies. So, okay, let me move I think we've passed this. Okay, so that's what's happening. We're trying to analyze as well in epidemiology so that we can identify risk factors. All right, then the fourth thing is what? Disease prevention. Remember that we are not just stopping at learning about the disease for learning's sake. That's not why we are learning. Is so that we can do what? We can prevent disease, so that we can improve health outcomes. So that's part of the functions. And then we have health policy development and evaluation. So health policy depends a lot on epidemiological data. We have to provide evidence. It is through data that we can generate evidence and now be able to formulate policies. So that's for this for definition of epidemiology, the definition and the core functions of epidemiology. So we mentioned 5 things. We said disease surveillance and monitoring. We said disease outbreak investigation, risk factor identification and analysis, disease prevention and control, and then health policy development. So the reason I'm skipping all these other pages is because it's a lot of history that we've looked at before. Okay, so the next concept we're going to look at is the concept of disease causation. That's the next thing that we are going to look at. The concept of disease causation. Please, are we following? Are we following, please? Okay, okay. Thank you. Okay. I see the reactions. Thank you. Okay, so let's get back to the material. All right. So the next thing we want to talk about is the concept of disease causation. And honestly, I would have preferred to like use diagrams and pictures to explain this, but really I've not been chanced to do that. So I will just try to explain and hopefully we understand what it is that we want to talk about now. Okay? So before epidemiology became a scientific discipline, we just based our entire study on observation, on looking. And then people started saying we need to go beyond that to now find out what actually causes disease. Remember that in when we did the history the last time, there were different things. People would say it's bad air. When you inhale bad air from something that is decaying, miasma, that's what causes illness. And then other people will say, it's the gods are angry, or that's why it's happening. Or some will say you committed sin. So there were different, theories or different concepts as regards what causes disease. But as time went on, we now came into the era of evidence, and then people could now start researching on things, and there was empirical research, which was started around the time when microscopes were created or something. That was when people now started knowing that, okay, so there are things like microorganisms. They are actually particles. They are things that we cannot see with our eyes that are causing diseases. Okay, so there was some explanation up here. Let me see. Disease causation is a cornerstone concept in public health and medical sciences. Understanding the mechanisms that lead to disease development requires exploring a complex interplay. Just plenty talk, plenty talk. And then down it says that diseases can be categorized, okay? So diseases can be categorized into infectious and non-infectious. So when we talk about infectious, we already know what we're talking about, right? We're talking about pathogens. We can't see them with our eyes. Living organisms, microorganisms, we can't see them, but they get into the human body and they can cause diseases. Then non-infectious, there are things resulting from, genetic predisposition, environmental exposure, and all the rest. So let's go back to what we were talking about, the disease causation. So we've already said that in the pre-scientific era, there were different ways that we talked about diseases, or different things that people said causes diseases, up until when, microscopy came into the picture. And then we now had something revolutionary, which was brought about by Louis Pasteur and Robert Koch. Those two people, they were the ones who were able to establish that these illnesses that people are having, oftentimes when we go under the microscope and we take samples and we go under the microscope, we see things that are living. We see things that are mobile. They are moving. Louis Pasteur also was the one who talked about how that fermentation is caused by microorganisms. So it was at that point that people started realizing that beyond the world we can see, that they are actually like microorganisms that we cannot see, and these things they have the potentials to cause diseases. So that was what brought about the germ theory. So we moved from the pre-scientific era where, people were just bringing all their different ideas, miasma, the gods are angry and all of that. Then we transitioned into a very key period where we now had the germ theory. So that germ theory was one way that diseases were explained. That was one way that they said this is the causation of illness, or this is the causation of disease, that is caused by germs. It's caused by microorganisms. That's what causes it. And at that time, even though now we've gone past this level of causation, but at that time it was revolutionary. Why was it revolutionary? Because now we could start thinking about antibiotics. Say, okay, if it is germs that causes this thing, then we should find something that can kill these germs. And then, that was where they started moving on to talk about how they can develop penicillin and all the early antibiotics and streptomycin, which they use for tuberculosis then. Then they started thinking about things like vaccine. So that was why it was revolutionary, because now we can say we know to a good extent what causes disease. Okay, now if you're following this definition if you're following this model of disease causation, you will see now that the assumption is that for every disease there's a particular disease causing agent. That was the assumption then. So they will say, okay, if somebody has cholera, it is caused by Vibrio cholerae. If somebody has tuberculosis, it is caused by Mycobacterium tuberculosis. So they were saying for every disease, there's a causative agent. But the limitations of this germ theory is that if you think of it now, we will see that it is not actually the case for all types of diseases. So if somebody has hypertension, for instance, what would we say is the microorganism that is causing it? Nothing. So the theory needed to move further. We needed to start asking ourselves, like the epidemiologists, then they needed to start asking questions that, okay, that there are diseases that we can't pinpoint. We can't say that this is the single infectious agent that is causing this disease. So they needed to move from that germ theory to the next model of disease causation, which was now a triad, which is referred to as the epidemiological triad. I'm sorry that we don't have like images and all of that, because I know that it helps a lot, but man, it's going to take time, and yeah, let's just manage with this. Okay. Okay, so there's a picture here of the epidemiologic triangle. Is also called the triad. So what's this triangle saying? All these round parts we can see, all these round parts, these robo, they call them nodes. So there's the host, there's the environment, and there's the agent. So it was this model was saying that for disease to happen, there has to be a host. There has to be a host. That's somebody who is susceptible, somebody who has the capacity to fall ill, basically. That's what the host is. And then there has to be an agent. The agent is the thing that will cause the disease. And then there has to be an environment. And that environment is not compulsorily like physical environment, but for what's it called? For infectious diseases, mostly it is physical environment. So the example we have here is the example of malaria. So the host here is the human being, and then there's standing water, which is the environment that enables the agent, the disease-causing agent that enables it to thrive. So they started explaining diseases. They were saying, okay, let's move a bit from this germ theory and transition into this model, this epidemiologic triangle, to start seeing disease, to start seeing that there's an interaction between different things, between the host, the environment, and the agent. And when these things interact, that is when disease will now occur. After this model, we moved ahead to now go to the next model. So the next models, they were now more multifactorial. And the model here is the web of causation. That's one of the models here. If you Google on your phone, maybe Google something about the web of causation for cardiovascular illnesses, you will see how it is actually like a web. There are so many factors there. Basically, what this web of causation is saying that for a disease to occur, there are just too many things that will happen. Too many things. They have to interact. Maybe the person's immunity becomes low, and the person already has a genetic predisposition to getting that illness, and then the person is not now eating well, and then the person is from a poor socioeconomic status. So it's saying that there are so many things that, they have to come into play for disease to occur. That was that web of causation. So we're moving away from it is one thing that causes disease. We move to the triad, and then move to it is multifactorial. Now, as time goes on, we realize that, okay, it's not like there's one best model. It's not like there's one best model. It just depends. There are some diseases that it's one thing that we cause, and there are some diseases that they have so many things that have to come into play for them to happen. And then there are in some situations where their particular models are preferred. For instance, we've talked about web of causation. Now we want to talk about the socio-ecological model. The key thing about the socio-ecological model, like I was saying, that there are some instances where you prefer one model over the other, is because it works better when we want to implement policies. It's more helpful when we want to implement policies. Why? Because it talks about diseases at different levels. It talks about it in terms of the individual. What are the individual things, the individual factors that can predispose a person to getting an illness? So there we're now talking about this individual's immunity, this individual's genetic composition. And then what are the interpersonal factors? What are the community-based factors, organizational factors, societal factors that would have impact on health outcomes that will predispose people to diseases? Now, when they are arranged in levels like this, it is good for policy making, because you know where to channel your policy to, whether we should focus on the individual, we should focus on the interpersonal, at the community level, at the organizational level, or what other level that there is. So that's the socio-ecological model. Then there are so many other models, but like the biopsychosocial model, but they were not mentioned here. So we're going to leave those ones alone. The other ways that we can talk about disease, causes of disease, is to talk about them in terms of necessary and sufficient causes. I really wish like we had diagrams to explain these things. So let me explain what a necessary cause is. Necessary cause is a cause that has to be present for a disease to happen. But the fact that it is present does not mean that that disease will happen. So let me explain. For instance, let's use tuberculosis, Mycobacterium tuberculosis. That Mycobacterium tuberculosis, that microorganism, if you check in people who are healthy, you will likely find it there. But they have it, but they are not sick, but they don't have the disease. So the first thing we are establishing with that example is that having that mycobacterium is not enough to cause the disease. Because, like I have said, there are people who are healthy. They are perfectly fine, moving all around. They are healthy. But if you check, you would see, if you check their respiratory system, you will find Mycobacterium tuberculosis. Now, probably because their immunity is very good, they don't come down with the disease. So the fact that Mycobacterium tuberculosis is present does not mean that a person will develop tuberculosis. The fact that that microorganism is present, it does not mean the person will still come down with that disease. Now, here is where it gets a bit tricky. If that Mycobacterium tuberculosis, if that microorganism is not present, then the disease cannot happen. So let me explain what it is like. That Mycobacterium tuberculosis is just like a chief. He has to be there. He has to be there before the meeting will start. If that chief is not there, the meeting will not start. So the microorganism has to be present because that is what will actually cause the disease. That is the thing that is going to start the entire pathogenesis of that disease is the Mycobacterium tuberculosis. But even if it is there, if other factors are not present, the disease may not happen. So Mycobacterium tuberculosis in this case is what we refer to as a necessary cause. That oga, it has to be there. The oga has to be there for this thing to happen. It's a necessary cause. But if that oga is there and other people have not come, meeting will not still start. It's a bit confusing, but I don't know how else to explain it. So that microorganism has to be present. If it's not present, see the name tuberculosis. It's coming from Mycobacterium tuberculosis because that is what will cause it. If it is not there, the person cannot have tuberculosis. If Mycobacterium tuberculosis is not there, you can't have tuberculosis. But Mycobacterium tuberculosis, the presence of it alone is not enough to cause the disease. The person's immunity has to be down as well. A lot of things have to come into play before it can now happen. But even if those other factors are there, let me say the person's immunity is down. The fact that your immunity is down does not mean you will now develop tuberculosis. No. It is until that organism is there before you can develop tuberculosis. So it's referred to as a necessary cause. It must be present for that disease to happen, but only him by himself, he cannot start the process. Only him by himself, he cannot do it. He cannot start the process. But if he's not there, the disease can never happen. Never. So that's for necessary cause. Now, the other thing is sufficient cause. Sufficient cause is a set of conditions that inevitably results in disease, which means if these conditions are there, bam, you must have the disease. So the example they gave us here is somebody who already has a genetic predisposition to developing lung cancer. So you already have the genetic predisposition, and then you now decide to now smoke. So those two things, they are like sufficient cause that when this one is there, you know that thing they say that is collabo. This one is there, the other one is there. Together, they are sufficient. They will cause the disease. The reason it is important for us to know necessary cause and sufficient cause is because it also informs our the way we target our intervention. For instance, if my aim is to bring down the burden of tuberculosis in a society, and I don't have enough resources. Instead of saying, okay, oh, let's build immunity, let's do this, let's prevent overcrowding, let's do the other one, let's ensure that people, there's all of this prescription on how many people should sleep in a room and all of that. Instead of scattering efforts all over the place, we will target our efforts. We'll be able to target it and say, let us target that necessary cost, let us target that oga, let's target it directly. So in that case, we'll be looking more at vaccination. Because if we remember that what we said is that we want to reduce the burden of tuberculosis, right? Now, if we go to say let's build up people's immunity, we go to say let's provide better housing conditions so that there's no overcrowding. Let's do that. And all these things we are doing, they are good though, but they will not really help us meet the goal that we want to meet. We now have to go for the necessary cost directly to say this necessary cost, let's target it. Why? Because if a person is vaccinated, whether your immunity is low, whether you are sleeping in crowded areas, because you're already, because the organism is not present, if we have eliminated it, then it means that the person is not going to develop that disease. If there's no tuberculosis, nobody is going to get tuberculosis. That's the point of it. So target your effort at that necessary cost. Now, for sufficient cost, remember that this one is mostly like a combination. It's like collabo, like many things coming together, and then whenever they are present, the disease will manifest, or it will bring about the presence of that disease. So in these cases, we can be talking about, okay, what can we do to reduce the risk factors for the person developing this disease? If it's a disease that, like this example we have here, there's genetic predisposition and there's smoking, and we say, okay, we may not be able to do anything about the genetic predisposition, but we can talk to people to stop smoking, to reduce smoking, such that even though you already have the genetic predisposition, because you don't smoke, it drastically reduces your chances of developing this disease. I hope that it helps in whichever way it is. Then the other way to talk about causes is now proximal and distal. So proximal cause is the direct cause, the thing gong directly, while distal causes are more like they will cause the thing that will result in that direct cause. So if, for example, we are talking about cholera, if a person takes in contaminated water, if you're exposed to it, who is drawing on my screen? If you're exposed to it, what happens? You and the organism, you will make contact, and then you will come down with the disease. Now, that direct exposure to the water was what caused it. That's an immediate cause, a proximal cause. But when we want to talk about distal causes, it's now like the things that brings you in contact with the direct cause, that makes you have that direct cause available. For instance, if you don't have money, you are likely going to be more exposed to contaminated water. If a person is poor, you are likely, like, very poor, because being poor does not necessarily mean unsanitary. But you're likely going to maybe be forced to stay in environments where they are like unsanitary conditions, even if maybe you don't want to stay there, but you'll be forced to stay there. Now that becomes an indirect cause. That socio-economic factor, the fact that the person has a low social economic status, it now predisposes the person to unsanitary conditions. It predisposes the person to making more contact with water that is contaminated. So that is now like an indirect cause or a distal cause. Okay? So when we talk about when we are talking about the disease causations, these are the various things we should just have in mind, that you can talk about it in terms of necessary and sufficient causes. These sufficient causes, there's a lot more to it. There's something called the Rothman causal model. And then we have to talk about, there's a pie. Like, I really wished there was a way I could have gotten all of those diagrams, but I really didn't have the time to. Okay. Then we can talk about causation in terms of proximal versus distal, and then we can talk about causation in terms of all of these other models we have here: epidemiologic triad, web of causation, social ecological model. Okay. So we're going to now talk about, I think that may be like we're going to talk about the natural history of disease and how it ties into levels of prevention. That's the next thing we're going to talk about. So I have like one image that I had here when I was trying to, let me see. Okay. So if you see the screen, this is what we are going to use to explain the natural history of disease and talk about prevention. So far, we've talked about the definition and core functions of epidemiology. We've talked about the key concepts of disease causation. I would really implore us to like look it up, that's disease causation, like get better explanation. I don't think that I've explained it so well. Okay, then now we want to talk about the natural history of disease and the levels of prevention. We're going to talk about these two things together. Okay, so natural history of disease. What we are talking about in this natural history of disease is how a disease, how a disease starts up until the end of the entire process in situations where there is no intervention. In our material, it said with or without intervention. That's not correct. That's not correct. When we are studying natural history of disease progression, we are looking at how does this disease start to the end of it. How does it progress? If you don't interfere, how does it progress? That's why it's natural. We are looking at it. Say somebody somebody gets infected. How does it go from that infection up until the final stage, which is the outcome stage? How does it progress through these entire stages? If there's no interference, if say we don't give antibiotics, we don't give anything. Okay, so when we're talking about natural history of disease progression, we're going to look at it we're going to look at it in phases. So the first phase here is called the stage of susceptibility. What is happening here is that you just have a person who is susceptible to developing the disease. What does it mean? It means the person is not yet infected, or the person, that's for if we're talking about infectious diseases. If we're talking about non-infectious, it means the person doesn't have the disease yet. So you are susceptible, you don't have it yet, but there's a tendency, or there's a propensity that you can have it or you may have it. So what we are saying is this person doesn't have it yet, but if this person becomes exposed to a causative agent or something that can cause it, then the person is likely to have it. So let's use something like let's use HIV for instance. If a person is not infected, a person doesn't have the infection yet, the person is at the stage of susceptibility. It means you don't have it yet. But that you don't have it yet does not mean you cannot have it though. That's what this stage of susceptibility is. You are susceptible. So if you now come in contact with the virus, maybe due to unsafe sexual practices, or maybe due to whatever it is, you are now exposed to it. Now there's a higher chance that you can develop, you can now get that organism, the microorganism, that's the virus, into your bloodstream, into your body. So you will now move from the stage of being susceptible. You are no longer at susceptibility. You have come in contact with the exposure. If you can see my screen, I don't know if this thing is visible, but if you see, there's the stage of susceptibility in green, and then you now see this arrow pointing down from exposure down. So it's saying you were at the stage of susceptibility, but by the time the person now makes contact with the exposure, the person might now progress to the next stage. Now, the next stage is the stage of subclinical disease. So the person has now come in contact with the virus. You will now progress into the stage of subclinical disease. Now, what is happening in this stage of subclinical disease? It means that the virus is now in the body and is now causing changes. It's causing some pathological changes in the body. But the person is still going about living normal life. Like, you don't even know that anything is happening. So if you look, you will see, if you look at the arrow pointing down to that stage of subclinical disease, you will see pathological changes. So that's the key thing there. That, okay, you have passed from the stage of susceptibility, you have made contact with the exposure, and you have made contact with the disease causing organism, and now it is inside your body system, and now it is causing things, it's changing a lot of things, but it has not changed it to the point where you will know that anything is happening. That's this stage of subclinical disease. That's why it is called sub. It is still below clinical level. You can't tell that anything is happening. At this phase, the only way we will know that something is happening is, say, for instance, we do screening. So we say, come and screen for HIV. So by the time we run the test, we now see that, that the virus is already present. And then we do some other tests and we notice that changes are already occurring, even though it is not yet manifesting. It has not yet become clinical. So that's the stage of subclinical disease. Now, it will now progress. It will now progress to the next stage, which is now the stage of clinical disease. This is the point where you are going to the clinic. You are looking for a doctor. Say, this my body, yeah, something is happening, oh. Something is happening, I'm having some symptoms. That's now the stage of clinical disease, that there are now signs and symptoms such that you can now go to a doctor, you can go to see a physician, and they can say, this is what is from all of the symptoms you have mentioned, this is what is likely happening. Or you're going to run this test. You run the test, they tie everything together and say, okay, so this is the diagnosis. So that's the next stage. You go from being susceptible. Susceptible means you don't have it yet. But the fact that a person does not have it yet does not mean the person cannot have it. That's susceptibility. So you now make contact with the thing that will cause that disease process. That's the exposure. You're now exposed to that thing. And what happens? Sometimes it now progresses. And when it's progressing, it will usually move to the next stage, which is that subclinical disease. So it's already in the body, it's already causing damage in the body, but it's not yet at the level where it is manifesting. You now leave that stage of subclinical disease, and then we move to the stage of clinical disease, where you can now see what is happening. Now, from clinical disease, there's now what we call the stage of the outcome, or the stage of it's called outcome. Ignore what is here. is now called outcome. That's the next stage. And this outcome, it can now take different forms. Outcome is like the final stage. It can take different forms. What are the different forms it can take? We can give treatment, we can treat the person, and the person will completely recover. That's one outcome. So we'll be happy that, okay, the person has completely recovered. The second outcome can be that the person will recover partially but had a disability. So for instance, somebody develops, somebody comes down with a stroke. So the person doesn't die, right? But now the person is going to live with a disability. That's like partial recovery in a way. So there are different outcomes. The outcome can be complete recovery. It can be partial recovery. The other thing that can happen is something seen in some infectious diseases where the person becomes a perpetual carrier. A carrier means the disease-causing organism is in the person's body, but the person is no longer having any signs and symptoms. But the person can spread it, but they don't have any signs and symptoms. They can go about their lives. They can, live normally, but they have that disease-causing agent inside them, and they can spread it to other people. So that's the person is now a carrier. It's seen in things like I think typhoid. It's seen in diseases like typhoid. It's seen in diseases like herpes simplex, like herpes is seen there. And then sometimes in hepatitis, where the person is normal, the person is okay, but the person has that organism inside of them, and they can give it to somebody else. So that's another way, that's another outcome. And the other outcome can be the bad one, which none of us like the worst of them, which is now death. Now, this is the natural history of disease progression. So when we are characterizing diseases, when we're talking about diseases, it's something that is a way that we stage those diseases. The stage of susceptibility, what's happening at the subclinical level, what's happening at the clinical level, and then what is the outcome. So when you can understand this thing, then you can say, okay, I understand the disease progression for this particular disease. Now, why is this important to us? Why do we need to know it? It's because it ties back into prevention. It ties back into prevention. If you know the progression, if you know the road that the disease will follow, you will know where to stop it. You will know how to stop it. You will know at what point you can intervene. Okay, so now we're going to move on to now talk about the last thing we'll talk about this evening, which is levels of prevention. So if we can see the diagram or the image on this screen, we'd see that there's the top part, and then there are purple arrows at the bottom part. So let's look at the top part. See the way it divided it. It divided it into susceptibility, preclinical, and then clinical. Because this determines the type of prevention that we are bringing about. So if a person is still at the level of susceptibility, they have not yet developed that disease. I hope we're still here. Okay. So if a person is still at the level of susceptibility, they've not yet developed the disease. What we are doing at that stage is called primary prevention. So what are we doing? We are saying, you don't have it yet, and we don't want you to have it. We don't want you to have it. We don't want you to come down with that disease. That is primary prevention. Now, the kind of examples under primary prevention, please, we're going to end in a bit. I'm sorry, like it's 4 minutes past the time. The kind of examples under primary prevention, we now have things like vaccination. So we are vaccinating people that do not yet have the disease. If a person already has the disease, then it's just it's not really, we can't really do primary prevention anymore. So primary prevention is, we want to put things in place to ensure that people do not even come down with the disease. So the people we are targeting for primary prevention are those who don't have the disease yet. The other example there can be things like adding fluoridation of water to prevent dental caries. So there's this thing where, people can have cavities if there's not enough fluoride in, the water, or like if they don't have enough fluoride from diet or from water or whatever it is. So at the primary level of prevention, we make those things available. We give vaccinations. We do everything possible to ensure that people do not come down with the disease. That is primary level of prevention. There are a couple of things there are other examples of primary prevention. Now, the next one is now the secondary prevention. This one, we are now targeting people who are at the stage where, they are at that subclinical level. That's secondary prevention. That subclinical level where the disease have not really started to manifest. So for secondary prevention, what we are doing is we bring people who are apparently healthy. The word there is apparent. It means we think you are healthy, but we don't know until we confirm, until we screen. So we bring people who are apparently healthy, and then we carry out screening tests. What are we doing? We want to catch the disease at the early phase. That's the purpose of secondary prevention. We want to catch it when it has not gone far. Why? Because it's usually just easier to manage. It's usually easier to treat when a disease has not progressed, when it has not gone far. Okay? So we want to catch it at a very early phase. Before it starts to, before the signs and symptoms start to show, we want to be able to pick it up. So we carry out things that the name of the thing there is screening. That's the key word, screening. We screen so that we can catch it at that phase where the person don't yet have the signs and symptoms. Okay? Then the other level of prevention is referred to as tertiary prevention. In tertiary prevention, the person already has the disease. The person has started manifesting signs and symptoms of that disease. But we will not say, there is nothing we can do. We are going to say, okay, let's try to ensure that this thing does not get more complicated than where it is at now. That's what tertiary prevention is. So tertiary prevention is saying, yes, the person has developed a stroke, but the fact that you have developed a stroke should not mean that for the rest of your life, you should have a very poor quality of life. You should be able to be rehabilitated. So that's where rehabilitation comes into play. So the key word in tertiary prevention is what? Rehabilitation. We want to rehabilitate so that we can say, yes, so we know that you have had this disease, but it's not the end of the world. It does not mean you should never have a good life. So let us see how can we even do it so that you can still have a good quality of life regardless. That's tertiary prevention. And then there's a fourth level of prevention, which this image doesn't capture. It's called the quaternary level of prevention. They just added that one. Now, what that level is talking about is, okay, we know that, okay, the person has had the disease and, has had the signs and symptoms and everything. And, currently we have a lot of, a gamut of ways to treat diseases and tests you can run. We want to make sure that we are not overdoing, basically. In quaternary, he's saying, don't now overdo. Let's still do the ones that are necessary. Don't now overdiagnose and go and overprescribe. So for instance, a person comes down with the flu, don't now say, let me give you antibiotics, when you know that it is a virus that is causing it. And for viruses, we don't need to give antibiotics. Most times those things will just follow their natural course and they will come to an end. So don't go and overdo. Basically, that's quaternary level of prevention. Okay, so I think we're going to stop here. The other thing, because honestly, I'm tired. The other thing that the part of this that we have not talked about today is the measures of disease frequency. Measures of disease frequency. That's like the last part of this material. And basically, measures of disease frequency is talking about incidence and prevalence. And just to make it easier for us when we get back to read, we're going to stop soon, okay? So that we can go to rest. So to make it easy for us when we get back to read, when we're talking about frequency of disease, we're concerned about two major things: incidence and prevalence. Okay? And for incidence, it means basically we're looking at new cases. We're checking for new cases of that disease. First of all, it's good for us to even know why do we even need to know all of these measures of disease frequency. If we don't know the measures, we can't even be talking about whether we're having an outbreak or not. But by the time we have all of this data, then we can say, yeah, this disease is increasing, or the prevalence is now getting high, or the incidence is increasing. And so these are the ways that we can know that it's time to intervene, or even to know that, okay, we are doing well, the incidence is reducing. Also, another thing is to be able to make comparison between different populations. So we need like standardized measurements. So that's where we talk about measures of disease frequency. So when you hear measures of disease frequency, you think of two things. You think of incidence, you think of prevalence. Incidents are new cases, people who are just developing the disease, or the events, the health related events that you are interested in as an epidemiologist. While prevalence are all the people that have that disease, whether the person is just developing it or whether the person have always had it, everybody together. But incidence is focused on new cases. Okay, and then when we want to talk about it, the concept of population at risk. So it's explained below that we have to define the population we are working with. For us to say there's an incidence of this, incidence of this in where? Which population? Among which people are you talking about? So we have to define the population, and defining the population, it involves being able to geographically define it in terms of the physical location of the population. You should be able to say this is where they are located. The people that we are studying the incidence of this disease on, this is where they are located. This is their location, their geographical location. We should be able to talk about the time that we are looking at. So if we are saying incidence around what time? Is it 2024? Is it 20? Which time are you looking at? What's the period we are looking at? We cannot just say, I want to study incidence and, the time is left open. Then we should be able to characterize demographically to say the people that we are interested in, the age, the sex. So we're studying this the incidence of this particular disease among people. Which age are we looking at? Which age of people are being affected? What's the sex? What's their occupation, their socioeconomic status? It helps us better bring it down to say this is the particular population that we are studying. And then, we have things like inclusion and exclusion criteria. So, yeah. Then our notes, the material goes ahead to now talk about population at risk, and it went on to tell us the key things we should be looking at when we are talking about a population being at risk. We should look at, if we're saying that these people are at risk, first of all, why is it important for us to even look at a population at risk? It is important because it's usually the denominator for our measures. So if you want to say if you want to talk about incidence, we will now say the incidence is like how many people out of how many. So 5 out of how many people are developing that disease. So that denominator is the one down. And for us to talk about that denominator, we have to understand the thing referred to as population at risk. So that's what this part is talking about. So when you want to define your population at risk for any condition, the population, the people you are including, they must have the eligibility to develop the condition. Okay, so there's a lot of things listed here, which perhaps the next time we meet, we're going to continue from there. But today I am a bit tired. So I think we can just stop here. The next time we continue from there. Okay. Somebody was asking about the LMS material. Yes, I used the LMS initially. To get it, you will just check on your dashboard. Go to the course on your dashboard, you will see it. Okay, where I was reading from, there's like a textbook that we have on our LMS. So if you go to MPH 8103, you would see the material there, the course material. It is there. That's where it is. Okay. The diagrams, yes, I got the diagrams online. I wish I could get more, but I didn't really have the time. I'm so sorry. All right. Thank you, everybody. Please, tomorrow we need somebody to anchor. Please, tomorrow we need somebody to anchor. All right. Also, tomorrow we are going to have the session with our senior colleague where he will put us through on, how to go about our studies basically, and all of the exam thing that we have been talking about on the group. So thank you very much. I wish everybody a good night. Please, if you have questions, maybe you can send them on the group, then later I would answer them. Okay? I'm sorry, but today I'm a bit tired. Thank you. Good night. I hope we recorded this call.